Good evening, consultants, fellows, and colleagues on the call. You are welcome to today's meeting. We start with a presentation by Dr. Demowo Ulusanya on arrhythmogenic right ventricular cardiomyopathy and restrictive cardiomyopathy. Dr. Ademowo, please, your audience.
There are two parts to the presentation tonight. There are two parts to the presentation. The first part, I said, let me start with the one that has fewer slides. And that's we're discussing the arrhythmogenic right ventricular cardiomyopathy. And the second part will be restrictive cardiomyopathy. The slides are a little bit voluminous, so I'll try to be very fast so that I will not bore us. So the outline for this will be with this. So ARVC is also known as arrhythmogenic right ventricular dysplasia, is an hereditable heart muscle disorder that predominantly affects the right ventricle. And it results in progressive loss of right ventricular myocardium, and its replacement with fibrofatty tissue is usually the pathological hallmark of the disease. And it's a leading cause of arrhythmic cardiac arrest, especially in young people and in athletes. The prevalence is estimated to range from 1 in 5,000 in general populace to 1 in 2,000 in some European countries such as Italy and Germany. And 50% of affected patients usually have a positive family history, and they may manifest with incomplete penetrance and limited phenotypic expression. And this can account for the underestimation of the prevalence of the disease in the community. The disease is transmitted as an autosomal dominant pattern, and it's more malignant in men than in women with a ratio of 3:1. And that might be explained due to the direct influence of sex hormones on the mechanisms involved in the phenotypic expression of the disease, or the sex-based differences in the amount or intensity of exercises that is peculiar to each sex. So the distinctive histopathological feature is the loss of right ventricular myocardium with substitution with fibrous and fatty tissue. And then there is patchy inflammatory infiltrates, mainly the T lymphocytes. They are seen when replacing the dying myocytes, suggesting that the pathologic process may be immunologically mediated. So the fibropathy scar progresses from the epicardium towards the endocardium, and then results in thinning of the walls with aneurysmal dilatation, which are typically localized in the inflow tract, that's around the subtricuspid region. It can also be seen in the outflow tract around the infundibular region, and at the apex, that's the triangle of dysplasia. So the inflow tract, the outflow, and then the apex can all be involved in these changes. In the typical form, the left ventricle is affected to a lesser extent than the right ventricle. However, there are disease variants that are characterized by an equivalent or even more predominant left ventricular involvement. The molecular genetic features, mutations in the genes encoding desmosomal proteins are important in the cell-to-cell addition. They play a key role in the pathogenesis of ARVC. So we know that ARVC is due to a mutation in the desmosomal proteins. So the cell addition disorder was suggested as a molecular genetic study when they discovered it when they were studying those that had Naxos disease. Naxos disease is, however, a variant, and it's autosomal recessive, characterized by cardiocutaneous syndrome that consists of skin and the hair. So the woolly hair, palmoplantar keratosis, and then ARVC. It's more in keeping with Naxos syndrome. However, Naxos is autosomal recessive. It's an MCQ question. The concurrence of epidermal and myocardial abnormalities in Naxos disease was explained by the fact that these two types of tissue have similar junction structures, and mutations in the genes encoding the plakoglobin were the first disease-causing variants to be identified in this group of patients. And plakoglobin is a major constituent of desmosomal complexes. So mutations in these genes encoding other desmosomal proteins was subsequently shown to cause the more common autosomal dominant form of ARVC. And then the proteins include the desmoplankin, the plakophilin, desmoglin, desmocholine, and the recessive mutation has been found to cause another cardiocutaneous syndrome, which is the Carvajal syndrome. But this one is not associated with all the woolly hair. So a tissue that replaces the myocardium contributes to the arrhythmia, usually of the ventricular origin, by slowing the intraventricular conduction and acting as a substrate for arrhythmias through a scar-related macro entry mechanism, which is similar to that observed after myocardial infarction. So life-threatening ventricular arrhythmias can result from mechanisms operating at the molecular and cellular level. So the desmosomes, the sodium channels, the gap junctions, they're supposed to interact synergistically to regulate additions, excitability, and coupling of the myocytes. This coordinated network of proteins located in the intercalated disc have been termed the connexosomes. The loss of expression of these desmosomal proteins may cause potentially fatal arrhythmias by inducing gap junction remodeling, with reduction of total content and substantial redistribution of the gap junction protein connexin 43, and decreasing the amplitude and kinetics of the sodium channels. So Brugada syndrome is a cardiac ion disorder that is caused by genetic deficiencies in sodium channels, which is also similar to what we are seeing in the ARVC. And then there's some evidence that Brugada syndrome and ARVCs, they may share clinical features and arrhythmic mechanisms as a result of their common origin from the connexosomes. So physical activity may aggravate mechanical uncoupling of the myocytes, and this will trigger the malignant and then ventricular arrhythmias due to the involvement of the gap junctions. So these are the histological features that infiltrates, and then these are the desmoglins in a normal tissue. They are needed for coupling, and then by the time you have mutation of this desmoglin 2 or any of the desmoglin proteins, there will be decreased myogenesis, and then there will be an increase in adipofibrogenesis, and then there will be an improper coupling, and the myocytes actually detach, and this would increase the chances of arrhythmias forming around all these abnormal structures. So the clinical features, they are usually apparent between the second and the fourth decades of life. The clinically overt disease is preceded by a preclinical phase, which is characterized by minimal or no structural abnormalities. And then sudden cardiac death might be the first manifestation of the disease. The most common presentation is palpitations or effort-induced syncope in an adolescent or young adults with T-wave inversion in the right precordial leads, V1 through V4 on the electrogram, presence of ventricular arrhythmias with a left bundle branch pattern, and the right ventricular abnormalities on imaging, that's echocardiography or other detailed imaging. So electrocardiography depolarization abnormalities, which reflects the conduction through the diseased right ventricular myocardium, may also be present. So usually the risk assessment is done when you have them presenting to you. The ones that is history, clinical symptom of aborted sudden cardiac arrest, or they're hemodynamically stable with sustained ventricular tachycardia, then they have the highest risk of 8 to 10% per year. So this is mandatory that they have an ICD insertion. So they're hemodynamically stable with sustained VTs, they are intermediate, severe dilatation or dysfunction. So that depends on the symptoms, and then what we see on examinations for these patients will allow us able to assess these patients and determine their risk of having an ICD. And then those that have lower risk, those that don't have symptoms, there is no syncope, even though there is positive family history of sudden death or indisability of PVCs, it doesn't justify the insertion of an ICD in this group of patients. So for the ECG and the echocardiographic features, sorry, please. So he said that they can have the T-wave inversion, which is what I mentioned earlier. So we can see T-wave inversion, V1, V2, V3, all the way to V4. And then depolarization changes. Those are changes. They have low QRS voltages on the limb leads, and then there's a delayed S-wave upstroke, and then the terminal activation duration, which is the nada of the S-wave, and the end of depolarization deflection is usually prolonged at 80 milliseconds. By the time we see it in this image, that's this duration is more than 80 milliseconds, and the normal value is supposed to be less than 55. So those are some of the abnormalities, the abnormalities that are seen on their ECG. Then they can also have the epsilon wave, which you can see in V1 to V2. There are some of the depolarization abnormalities that can be seen in those that have ARVC. So these are the repolarization abnormalities that are seen. These are the depolarization abnormalities. Some of these were mentioned yesterday when someone was answering. I can't remember who, but he explained some of all these features. So they have they can also have arrhythmias, ventricular arrhythmias, which you can see here because of the wide QRS complexes, and then they usually have a left bundle branch appearance. If I can read out the exact details with it. So ventricular tachycardia, the rate here is 160 beats per minute with a left bundle branch pattern, and it's part of. So they have what we call like RVOT tachycardia. So once you are seeing this kind of arrhythmias in these people, we should suspect ARVCs in them. Then the echo, you see here there's dilation of the RVOT. RVOT in this image is 38 millimeters. Normal should be less than 32. And then the cardiac MRI is showing aneurysms of the RVOT, which is the arrow. And then there's some fibrillopathy infiltration of the RV on these other arrows. So these are some of the images that can help in making an assessment of the ARVC. So typically the ventricular arrhythmias I mentioned, the LBB, and then the QRS would help to point to the site of the origin. So if it's an inferior axis, it's from the RV outflow. United can affect the RV outflow, the inflow, or even the walls. So or superior axis, that's if it's a superior axis, then it's from the RV inferior wall or the apex. So the inferior axis is outflow tract. So this is the diagnostic criteria for ARVC. Sorry. There should be at least two major criteria. So these are the major and the minor. Two major criteria, one major and two minor, or four minor criteria is what we need to make an assessment of ARVC. So for the categories, once there is global or regional dysfunction, structural abnormalities on the right side that we can pick on MRI, on echo, or RV angiogram. So the major ones are the RVOT more than 33, which is what we saw earlier. Then the RVOT more than 36 or there is RV, akinesia, regional akinesia, dyskinesia, or aneurysm, on angio. Those are major criteria. For the tissue, okay, let me just discuss the minor. So minor, if it's just like borderline, is close to that cutoff of 32 to 29 to 32, it's minor. And then if it's instead of 36, is between 32 to 36. And then the fractional area change is not so significant when on like 33%, which you are using as a cutoff here, then that will become a minor criteria. So for the tissue characterization, if there is a less than 60% residual myocytes, that means if you have fibrofatty replacement of at least 40% is replaced by fibrofatty involvement, then you should, and that's usually when we do endomyocardial biopsy, we can make an assessment. But if you still have like maybe less than 40 and 25%, or you have 50 to 65% that is estimated. You know, when we have less than 60 residual myocytes, that means just let me put it like that. So that means they've been involved with fibrofatty involvement. So repolarization abnormalities are the T-wave inversions on the right-sided precordial leads in patients older than 40 in the absence of right bundle branch block. And if there are T-wave inversions in older patients in the absence of complete right bundle, make it minor. The depolarization abnormalities are the epsilon wave, and then the late potential signals on ECG in at least one of three parameters in the absence of QRS duration of greater than 110. And some other parameters are categorized as minor. The arrhythmia, the presence of non-sustained or sustained sustained ventricular tachycardia with a left bundle branch block or superior axis, it's major, while the non-sustained or ventricular tachycardia of RV outflow with inferior axis and is categorized as a minor criteria. Then the family history, if there is first degree relative who meets the current task force criteria, then ARVC is confirmed pathologically whether pre or post-mortem or at surgery in any first degree relative. And then there is a identification of a pathogenic mutation, and then it's categorized as associated with or probably associated with ARVC, then it's a major criteria. And then history where it's in whom it's not possible or practical to determine, where it's just been suspected and then sudden cardiac death, but we are suspecting that the family history is categorized as a minor criteria. It's also important to note that some of them are classified as possible. If it's possible diagnosis, if the patient meets one major and two minor from different categories, and then I think I've mentioned all the. Okay, no, this is what I wanted to mention. So let me just move on. Genetic testing, it does not exclude the possibility that the phenotype is due to a mutation of an unknown disease-causing gene. And it has been reported that 16% of LD persons may actually have this missense mutations, and they may not have any clinical manifestation of the disease. The treatment aims at the aims of clinical management is to reduce the risk of cardiac death and improve the quality of life by alleviating arrhythmic and heart failure symptoms, and restriction of intense sport activities regarded as an important preventive tool for both LD gene carriers and clinically affected persons in order to prevent the risk of having exercise-induced malignant events. So lifelong clinical assessment with the use of non-invasive tests is important. It's done every 2 years and is warranted, because the fact that the heart is normal doesn't mean that over time the age-related penetrance might not manifest. So the patients who are those that have the genes must be followed up for life. So despite the limited supports, that beta blockers are currently recommended for all clinically affected persons for prevention of arrhythmias and reduction of right ventricular wall stress. So in patients with ventricular arrhythmias, antiarrhythmic drugs offer the potential to ameliorate symptoms, although there is no proof that it confers protection against sudden death. Amiodarone alone or in association with beta blockers or sotalol are the most effective drugs when they are combined or they are synergistic effects. And then catheter ablation is a therapeutic option. However, because the fibrillopathy infiltration continues to occur, there will be formation of new scars as the disease progresses. So there will be new areas of macro reentry that can actually elicit arrhythmias in this patient. So there's usually a high risk of recurrence if they undergo catheter ablation. So most of the time, patients will benefit from defibrillators, but this has been found to be beneficial in those that have had an episode of VF or sustained ventricular tachycardia. And there is no indication for prophylactic defibrillation implantation, because especially in those that have low risk. And this is because of the risk of device related complications during long-term follow-up that can be as high as 3.7% per year. Those that have heart failure should be given the normal pharmacological therapy, and then oral anticoagulants should be given to those that have atrial fibrillation and cardioembolic complications, while cardiac transplant is the ultimate therapy for those who have untreatable arrhythmias. So these are some of the differentials, idiopathic RV, tachycardia, sarcoidosis, which can also give, sarcoidosis will give you patchy infiltrates, which and can affect either of the ventricles. Myocarditis too can present similarly because of the arrhythmias that are there with it, but usually there may be prior viral infections or any other infections before the myocarditis. And then dilated cardiomyopathy, also associated with arrhythmias. And then because as the disease progresses, AR visits to the walls will thin out because of the fibers, and then they might mimic dilated cardiomyopathy. All of that differentials are also listed there. Then, so the risk factors for sudden death, prior cardiac arrests, fast or poorly tolerated beating, unexplained syncope, physical activity or sports activity, and then those that have young age at diagnosis, hemodynamically stable, with persistent hemodynamic, even though they are hemodynamically stable, sustained beating, they are at risk of sudden death. And then those that have severe RV dysfunction or LV involvement, especially at a young age, they are at risk of sudden death. So questionable risk factors are those that have family history, QRS dispersion, inducible ventricular stimulation, electroanatomical scar, and the molecular genetics proband status or premature ventricular complex and alter more than 1,000 in 24 hours. So they are like intermediate or questionable risk factors for sudden cardiac death. And the prognosis is characterized by the occurrence of arrhythmic events, which can cause sudden death and impairment of biventricular systolic function and eventually lead to death from heart failure. The mortality range is from 0.08 to 3.6 per year. Prior cardiac arrest due to ventricular fibrillation or VT are the most important predictors of life-threatening arrhythmic events. And then the major risk factors, which were highlighted in earlier, presence of arrhythmias or involvement of both ventricles are significant risk factors. So these are some of the references I used for this slide. Thank you very much. Let me move to the second part of the presentation. Restrictive cardiomyopathies. I'd like to thank Dr. Olalekan. I'm using his slides for this particular part of the presentation. I'll be discussing based on this outline. Cardiomyopathies are defined as a myocardial disorder in which the heart muscle Sorry, please give me a few minutes. Disorder in which the heart muscle is structurally and functionally abnormal in the absence of coronary disease, hypertension, valvular disease, congenital heart disease, and is sufficient to actually cause myocardial abnormalities. And restrictive cardiomyopathies are a heterogeneous group of diseases characterized by non-dilated ventricles, which sometimes initially they have normal or near normal LV ejection fraction, and is the least common of all the various cardiomyopathy groups that we have, accounting for 5%. The predominant manifestation is actually diastolic dysfunction. And RCM is a restrictive left and or right ventricular pathophysiology in the presence of normal or reduced diastolic volumes, normal or reduced systolic volumes, and normal ventricular wall thickness. And it's commonly presents as biatrial enlargement due to the impaired filling in diastole that occurs in this condition. And initially, the ejection fraction, the systolic ejection fraction might actually be normal, and then they may not present throughout at an initial stage, and then they gradually progress towards the hypokinetic dilated state. And then restrictive cardiomyopathy or restrictive ventricular pathophysiology can occur in those that have severe hypertensive heart disease, aortic stenosis, end-stage OCUM, and end-stage dilated cardiomyopathy, where we have significant diastolic dysfunction due to end stage of fibrosis, fibroelastosis, and then thrombosis that can occur in all these other causes of cardiomyopathies. And then the cause varies, depends on the pathology and the treatment. It's been a significant cause of heart failure with preserved ejection fraction, although there is a clinical overlap between RCM and other forms of heart failure. So this makes the diagnosis of RCM very challenging. And in the past, diagnosis was majorly made using endomyocardial fibrosis, but things have become easier now, and cardiac MRI can be used to make an assessment. So there's been a reduction in need to do endomyocardial biopsy. So sometimes the cause might not be known, it's idiopathic, and then whether a cause is found or not, once you make an assessment of restrictive cardiomyopathy, you must do genetic screening and do a family survey or search for the disease. So if it's familial RCM, it can affect 30% of cases, and the genes that are linked are the sarcomeric genes, which are autosomal dominant, the EDS genes, which can be dominant or recessive, FLNC, which is autosomal dominant, BAGS, which is autosomal dominant, and then the rasopathies, which can be dominant or recessive. RCM is rare in adults, and that's the idiopathic, the familial one. Can occur in children. You can see the prevalence is very small, 0.0003. Male and female are affected equally. And low flares endocarditis is one of the leading causes of restrictive cardiomyopathy in the temperate region, while in Africa, it's been thought that EMF is one of the leading causes, even though we all know that the prevalence of EMF in our environment has been on the decline, because it's more with poverty, and it's like things are getting better. So these parasites are probably linked to EMF. are on a downward trend. So RCM may be caused by various local or systemic disorders, and it can be primary, it can be secondary. So the secondary ones are the amyloidosis, EMF with or without hypereosinophilia, and it can also be acquired. It can be obliterative or non-obliterative. Obliterative when you have the thrombus forming ones that will actually fill the ventricles, but this form is usually very rare. And then the non-obliterative one is the idiopathic primary type, which will cause progressive fibrosis of the myocardium without necessarily causing thrombus formation. So it can also involve the myocardium itself or the endomyocardium. The myocardial involvements, we have the non-infiltrative, infiltrative, storage diseases. So these are some of the non-infiltrative causes: scleroderma, pseudoxanthoma elasticum. The infiltrative ones, amyloidosis, sarcoidosis. The storage disease, that's hemochromatosis, Gaucher's. So all these Fabry's disease, glycogen storage diseases, iron overload, and all these glycogen storage diseases can present with a myocardial involvement, while the endomyocardial ones are the obliterative and the non-obliterative. The obliterative is endomyocardial fibrosis and the hypereosinophilic syndrome, because they are more prone to have LV thrombus formation, while the non-obliterative carcinoid, malignant infiltrations, and the iatrogenic due to radiation and drugs can cause endomyocardial restrictive cardiomyopathy. So the disorders can also be classified as those that are due to intrinsic myocardial dysfunction or interstitial fibrosis, interstitial infiltration, cardiomyocytes, accumulation of storage materials, or endomyocardial fibrosis. So these are some of the causes which have been highlighted initially when we were subdividing into endocardial and myocardial causes. I won't bore us with that. So pathophysiology, there's increased stiffness of the left ventricle, termed rigid myocardium, and this is the basis of diastolic dysfunction. So this rigid myocardium will lead to increased ventricular pressure during diastolic filling phase, and then impaired ventricular filling, and with time there will be decreased ventricular wall compliance. So this increased pressure during diastole will cause some rise of increase in the volume as a result of the stiff myocardium. So this pressure is transmitted back to the right. So there'll be an increase in venous pressure causing right-sided failure because there's no forward flow. That stiff LV will prevent forward flow. So it will go back. So with time, they'll have right-sided failure, and then there'll be hepatic congestion, hepatomegaly, ascites, elevated JVP, and then edema. So the poor ventricular filling will lead to poor forward flow. So there'll be a reduction in stroke volume, and then there'll be tissue hypoxia. There'll be muscle hypoperfusion that will lead to fatigue and weakness. And then with time, because of the hypoxia, there'll be breathlessness, tachypnea, that will result at the stage, the ventricles will still feel at low pressure, and it will not be able to actually overcome with time. It's not be able to overcome that elevated pressure. So for causes of restrictive cardiomyopathy, so for amyloidosis, so there's abnormal deposition of amyloid protein, fibrotic process for EMF, hemochromatosis when there is increased iron in the myocardium. So all of these will come together cause stiffening of the left, and then there'll be increased pressure during diastolic filling. The pressure propagates to the right side. Then there's increased venous return. There'll be impaired ventricular filling that will affect forward flow, hypoxia, tachycardia, fatigue. Then there'll be decrease in ventricular wall compliance. So it will be initially easy to fill. Then when it eventually fills due to the very high filling pressure, it will send it back to the right, which will lead to elevated JVP and then a fault at sounds because the atrium is trying to pump into a non-compliant ventricle. So the clinical presentations, which I've already listed, autopnea, fatigue, left-sided symptoms too can also occur, shortness of breath due to hypoxia to chest pain is rare but may occur in amyloidosis, or it can occur due to angina. And chest pain can actually mimic myocardial ischemia due to myocardial compression of the small vessels. And some of them may also present with thromboembolic complications, DVTs and Ps, syncopes and sudden cardiac death, ventricular arrhythmias due to fibrosis that will occur in the walls of the ventricles. And even those that have a mixture of radiation, they can also be more prone to arrhythmias. Weight loss and cachexia are not uncommon. And then there is associated easy bruisability, periorbital purpura, macroglossia, carpal tunnel syndrome, hepatomegaly. They should suspect cardiac amyloidosis. A loud early diastolic filling sound, that's the third sound, may be present, but it's not commonly seen in amyloidosis. They can have a fourth art sounds, though that's also very rare in cardiac amyloidosis. They might have coexisting MRTR. Those that have coexisting learning difficulties or developmental delay, we should think of Noonan syndrome, neurological signs, carpal tunnel syndrome, think of amyloidosis. If there are muscle weaknesses, we should think of desminopathies. Their ECG is one of the first tests to diagnose them, and it's usually abnormal in about 90% of patients. But at the early phase of a disease, the ECG might be normal. And if you have low voltage QRS complexes, you should suspect amyloidosis. And it's also important to know that the absence of low voltage does not exclude the diagnosis. It might be picking the patient at the very early stage of a disease manifestation. Atrial fibrillation can be seen in up to 74%, and usually you have to anticoagulate them. Significant ST depression might mimic ischemia, and then some conduction abnormalities and arrhythmias, AV blocks can also be seen. So to evaluate these Doppler studies, cardiac CT, MRI, biopsies can be done to confirm our assessments. Some of the first level tests, creatinine kinase, ferritin, because of all the causes. Once you're suspecting restrictive cardiomyopathy, we want to know what exactly is the cause of this condition. So these are the first level tests that we'll do. We want to rule out infiltrative diseases, iron deposits. We want to confirm your heart failure, their baseline liver function test, and ACE for sarcoidosis, iron for iron overload, troponin to rule out ischemic heart disease in them. Then urine and plasma protein immunofixation for amyloidosis, and the free light chain for light chain amyloidosis. So the second level tests are those that are also organ specific for sarcoidosis, and then all the immunologic causes. So the diagnosis can be very challenging, and due to multiple modalities of investigations and the high index of suspicion must be in place before that assessment will eventually be made, so we don't miss it. There is no specific treatment, and the therapy is directed at the individual cost if it has been proven and then it has been discovered. So it's use of the normal goal-directed medical therapy that we use for heart failure. Arrhythmias, we give antiarrhythmics. and anticoagulations when they have atrial fibrillation. Steroids can be of benefits in sarcoidosis and low flares and endocarditis, while endocardiectomy can be of benefit in EMF, endomyocardial fibrosis. Phlebotomy and chelation can help with the iron overload in hemochromatosis, chemotherapy, mephalan, the tafamidis, and all the other medications can be used if we are thinking of amyloidosis. Budesonide is the steroids that is preferred in those that want to use steroids for. And I mentioned it earlier that sarcoidosis can use steroids. So budesonide is a potential anti-inflammatory with fewer side effects than other oral corticosteroid therapy. So pacemakers, if they have conduction abnormalities, and it's important to note that we avoid digoxin in amyloidosis, because to bind to the amyloid abnormal proteins. So the differentials, constrictive pericarditis, acute chronic heart failure, hypertensive heart failure, OCUM. We have explained how all of these can be significant differentials. I think we can look at this table because of time. I will run through. So complications, thromboembolism, arrhythmias, cardiac cirrhosis due to right-sided involvement, pulmonary hypertension, and death. And then prognosis is poor prognosis. 2 to 5 year mortality can be as high as 50 to 75%. And then they usually have a very poor quality of life and then prolonged course of heart failure. And those that are refractory to supportive therapy usually die of low output heart failure unless they have a cardiac transplantation. So I'll run briefly through some of the individual causes. So idiopathic, like I mentioned, can manifest in children, though the prevalence is very low, it's very rare. Symptoms are non-specific. Dyspnea might be the initial manifestation, and then is consistent with biventricular failure and raised JVP. There can be ascites, atrial fibrillation, and the third heart sound can be added in 25% of patients. ECG might be normal voltage initially, and then some of them might have complicating conduction delays. So the transthoracic echo will reveal biatrial enlargement with non-dilated ventricles, and then increased filling pressures. A careful evaluation, simultaneously recorded LV and RV pressures in respiration will show concordant changes in systolic pressures in RCM rather than a discordance. That's an inspiratory increase in RV systolic pressure with a simultaneous decrease in LV, which is seen in constrictive pericarditis. So this is transthoracic or idiopathic. You can see the way it's shining. So by the time you see this and you cannot rule in any other secondary cause, then we should think more of restrictive cardiomyopathy. So here we have the cardiac catheterization picture. So in constrictive pericarditis, we can see that in inspiration, in restrictive, there is no, how do I explain it? Let me just read the words here. So the changes on inspiration in RV, we can see that on inspiration, there is no drop in restrictive cardiomyopathy. There is no drop of the in the pressures by the time they take inspiration. Unlike in constrictive pericarditis, there will be a drop. That's the square root sign in constrictive pericarditis. So non-specific biopsy features, survival is usually poor. and most deaths are due to cardiac causes or secondary heart failures, and 1/3 might die due to non-cardiac causes. So treatment is just is medical, guideline-directed medical therapy, diuretics, and then so endocardial diseases. These are those that cause restrictive, that's EMF and hypereosinophilic, because they tend to form clots, and they share similar pathologies and are characterized by intense eosinophilia and thromboembolic phenomenon. It's a disease that was first described in Uganda and was initially termed tropical endocardial disease, and may well be the most common cause of restrictive cardiomyopathy worldwide. Most prevalent in Africa, Asia, South America, is very rare in North America, and it accounts for 10 to 20% of deaths from heart failure in Africa. In contrast, hypereosinophilic syndrome is seen in temperate regions, and there is no specific data on gender predisposition, although mixed findings on studies on gender distributions have actually been found. And then lower socioeconomic status is where it's actually that they are the ones that are prone to have EMF. And a study in Uganda showed that it peaks at age of 10 and at age of 13. So the exact etiology is not known. It can involve both ventricles, 50%, and then the LV, 40%, RV, 10%. The hallmark is the fibrotic obliteration of the affected ventricle, and it typically affects the apices of the LV and the RV, and then the posterior mitral valve too can be affected, and this can sometimes lead to papillary muscle and chordae tendineae manifestation of MR and significant TR. So in advanced stages, the calcific deposits and thrombus formations occur, which will obliterate the cardiac chambers, and then coronary artery obstruction is usually uncommon, and there are no extra cardiac involvements. So some of the factors that have been postulated as the cause is eosinophilia, which will cause myocardial damage due to ailments such as schistosoma, the arboviruses, the toxoplasma, and then some believe that the environmental exposure to cerium, which can contaminate soil and food. Some immunologic factors have also been postulated, and then some genetic factors, but they are all not clear. So there are three phases: the acute phase, where the patients might initially just have non-specific febrile illness, and then to move on to, so most of the time it's not picked at that phase. It's move on to subacute, and then subsequently chronic. So many of the patients present when the myocardium is already burnt out, and then where complications are prominent. So there is usually, when there is RV involvement, they can have giant V waves and a rapid Y descent. On investigating them, left atrial enlargements, atrial arrhythmias, low voltage QRS complexes, they can have all sorts of AV blocks. Echo is used to make diagnosis where the apical obliteration is seen with the clots. Then on MRI, there'll be myocardial fibrosis on late gadolinium enhancement, and then the full blood count will show eosinophilia, and then there could be associated hypoalbuminemia. So medical management is very challenging because many of them present when the disease is already advanced, and they tend to die within 2 years. The presence of atrial fibrillation is a poor risk factor. GDMT is what is given. And then even when they do surgery, that's the endocardiectomy to replace the valves, when there is valve involvement, it can help to improve survival, but mortality post-surgery can be as high as 20%. So low flares, which is what is common in the temperate region, some of the known causes are the involvement of the elements and parasites, malignancies, eosinophilic leukemia, allergy, and drug reactions, all are still with hypereosinophilia, as well as idiopathic hypereosinophilia syndrome. And then hypereosinophilia is defined as chronic absolute eosinophil count greater than 1,500 cells per ml for at least 1 month, or pathologic evidence of hypereosinophilic tissue invasion. And if this is persistent for 6 months or longer, then we can make that assessment of them. They will know that it's a strong risk factor, and is associated with gene 5q31, q33. It can affect the heart, though it's rare. So first stage, eosinophil mediated cardiac disease, acute, intermediate, and fibrotic. In the acute space, there may be no signs. Then myocardial biomarkers may be elevated. Second phase, thrombus formation, there might be T-wave inversion on ECG. Third stage, fibrotic changes, scarring of the valves. If the disease is identified, therapy can be focused on the underlying cause, the malignancies, the elevated eosinophils, the parasites. But in chronic phase, surgery can be done, endocardiectomy with or without valve replacement, and heart transplant is the definitive care. Post-sacchoid cardiomyopathy is a multisystemic disorder and is commonly seen in Blacks, more in women than in men, with a higher incidence in Scandinavians and Japan. It's also known as sacchoid heart disease. And the cardiac involvement, they usually present with heart block or ventricular arrhythmias. Sudden death, presumably from an heart block or ventricular arrhythmia, may be the first manifestation of sarcoidosis or the heart disease itself. And then the prevalence in those that have pulmonary sarcoid is said to be no more than 5%, but autopsy studies indicates a much higher prevalence, which can be as high as 25%. The most common clinical feature is biventricular heart failure. That can be MR, which is due to papillary muscle involvement, in addition to LV dilation. And then the granulomas have a prediction, they have a predilection for the conducting system, hence their high risk of having a high degree AV block, or even any form of atrioventricular block is one of the initial manifestations and clinical signs of cardiac sarcoidosis. So both atrial and ventricular arrhythmias are common. Once causes of AV blocks by Lyme's disease have been ruled out, then complete heart block in a young patient suggests sarcoidosis. Especially the ventricular arrhythmias are present, and images should be pursued, especially cardiac MRI, which will show involvements. How did they even put it? I know in discrete involvements of the
Okay.
So sudden cardiac death is always associated with grossly visible scarring and fibrosis.
Then, okay. Yeah, and crowd to one call up upper respiratory tracts. But maybe
it can be difficult to distinguish sarcoidosis from giant cell myocarditis unless systemic features of sarcoid are also present. So ESR is elevated. Yes, sir. So the ACE may also be elevated, but we know that we can't use serum ACE as a diagnostic tool. So usually it's cardiac MRI is what is used to confirm the diagnosis, and there is delayed gadolinium enhancement in a non-coronary distribution, usually in a non-coronary distribution, and is non-transmural and has a predilection for the basal or the mid-ventricular septum. So the basal and in patches. So 18 fluorodeoxygenase positron PET scan is complementary in cardiac MRI in patients with sarcoidosis reveals inflammation in active disease, permits serial evaluation in response to therapy, and is used for follow-up of these patients. Biopsy can be done, which will show non-cassating granulomas if the MRI is also not specific and not giving the typical presenting features of sarcoidosis. And standard heart failure therapy is what is instituted. Steroids can be given to these patients, especially when they are newly diagnosed. And then pacemakers are class 1 indication. ICDs, when there is an ejection fraction less than 35%, or there is a prior cardiac arrest. Cardiac transplantation too is an option for them. For cardiac amyloidosis, is the most important representative of infiltrative type and is seen in people as young as 40 years. There are over 95% of cases are due to deposition of hemoglobin light chains or transthyretin. So they're the two major subclasses of amyloidosis, cardiac amyloidosis. So in addition, myocardial damage occurs due to direct toxic effects of these abnormal proteins on the cardiac cells. And initially, it might be preserved ejection fraction, and then with time, it progressively worsens to reduce ejection fraction. They might have coexisting atrial fibrillation and particularly and thrombus formation, especially in those that have light chain cardiac amyloidosis. Patients with amyloidosis are usually resistant to conventional treatment, but a timely diagnosis of the targeted therapies that are now being in use might be beneficial. So those targeted therapies, the effects are best gotten if they are used early on in the disease process. So tissue biopsy might be done, though it's not like top on the line of making assessments again for cardiac amyloidosis. But when you have biopsy, I take from rectal pad, abdominal fat pad, or that's not really done again. But biopsy can actually show apple green birefringence when they are put under polarized light, while the Congo red staining will appear red under non-polarized light. So due to the high incidence of stroke, once they have atrial fibrillation, they are put on anticoagulants for life, irrespective of their risk score. Treatment is multidisciplinary. Chemotherapy is used. So if you want to stabilize the transthyretin precursors, we use tafamidis. If you want to knock down you want to do genetic silencers, we can use the patirisan and vutrisiran. These are best used in those that have familial ATTR. And it's noteworthy that these treatments target the precursor protein and are not the already formed ones and accumulated amyloids in the heart. So these are some of the other details and trials that have been done. So the ESC guidelines suggest use of tafamidis in patients with NYHA 1 or 2 without explicitly addressing the issue of patients in NYHA class 3, which shows the less convincing results. And in cases of mixed neurologic and cardiac phenotype, patirisan and inotersen can be considered. Those are the genes silencers. So heart and liver transplant may be considered in some patients who have advanced cardiac amyloidosis without severe neuropathy. You know, they are at risk of having cardiac cirrhosis due to the right-sided involvements that they can have. So radiation, as I said, RCM is a consequence of radiation exposure when they are treated for malignancy. It can occur as a consequence of inflammation or microvascular damage. There is no treatment, and the treatment follows general principle of heart failure, and heart transplant should be considered. For storage disorders, this is due to accumulation in the myocardium of metabolites, and they are typically caused by inborn errors of metabolism, such as the Anderson-Fabry disease, the mucopolysaccharidosis, the glycogen storage diseases like Danon, Pompe, Cori, Prague-2 cardiomyopathy. And they can have overlapping phenotypes. They can present as restrictive cardiomyopathy or hypertrophic cardiomyopathy. although many of them present as DCM. So their clinical manifestations, they tend to present with conduction abnormalities and valve involvement. So those that have Anderson Fabry disease, that's deficiency of alpha galactosidase A, they can be partially corrected, especially when they are picked up early by replacements of the enzyme, that is the agalsidase alpha or beta, which would actually improve the outcome or prognosis in this Anderson Fabry disease. At the cardiac level, the treatment is particularly effective if started before the development of irreversible fibrotic changes. As an alternative, the pharmacologic chaperone, that's a migalstat, has shown stabilization of the clinical course in this subgroup of patients. So the mucopolysaccharidosis, they represent a group of lysosomal disease that are called due to absence of functional enzymes that are needed to degrade the glycosaminoglycans. So this deposits in the myocardium, and current therapies differ according to the type that is involved. So there can be enzyme replacements, valve surgery, or hematopoietic stem cell transplant. So for iron overload, and it can be seen in those that have sickle cell, hemoglobinopathies. So in either case, iron binding capacity of transferrin is exceeded, and then this leads to deposition of iron in the organs such as the liver, the glands, the skin, the joints, and the heart. And it can complicate the cardiomyocyte function, lead to conduction abnormalities, and predispose to ventricular arrhythmias and sudden cardiac death. It can present initially as restrictive cardiomyopathy and progress to dilated cardiomyopathy. So the presence of serum ferritin levels greater than 300 nanogram per mil in males, or greater than 200 nanogram per mil in females, and a TSAT of more than 45% should prompt further diagnostic assessments. So these are some of the first-line screening tests that should be done when we have a case of suspected restrictive cardiomyopathy. This ferritin level, once they are elevated, 300 in males, 200 in females, and in TSAT of more than 45%, then we should think of iron overload. So therapeutic phlebotomy is the mainstay of treatment in these patients, especially when they are non-anemic and they are hemodynamically stable. It's important to note that the T2-weighted cardiac MRI is used to quantify the myocardial iron load, which inversely correlates with the ejection fraction and predicts the development of heart failure. So this therapeutic phlebotomy will reverse liver fibrosis, cardiac dysfunction, and the skin hyperpigmentation that is associated with iron overload. So there is removal of 400 to 500 mils of whole blood every 1 to 2 weeks, depending on the patient's tolerance, until the serum ferritin that was initially 300 in male and 200 in female is less than 50. And hemoglobin should be kept at more than 11 grams per DL to maintain that ferritin level of 50 to 100 nanogram per mil. Thereafter, then periodic phlebotomies can be done 3 to 4 times a year. Ion chelation therapies can also be given as adjuncts when phlebotomy is not effective. So carcinoid heart disease is rare and is due to elevated circulating levels of vasoactive substances, that's 5-hydroxytryptans, the histamines, bradykinins, tachykinins, prostaglandin, and it's a rare metastatic neuroendocrine malignancy, and is characterized by flushing, diarrhea, bronchospasm that occurs with hepatic metastasis. So they present more with right-sided symptoms, and when there is a cardiac involvement, there is also elevated urinary 5-HIAA levels, which are highly specific and moderately sensitive in the diagnosis of carcinoid syndrome. Echo will show, or cardiac MRI will show thickened immobile tricuspid and pulmonary valves with combined stenosis and regurgitation lesions. So once you see that in the setting of restrictive cardiomyopathy, we should suspect carcinoid heart disease. Therapy is not curative. may just be supportive, and then debulking of the hepatic lesions or the metastasis, and then the use of octreotide, which is a somatostatin analog, to bind to somatostatin receptors on the surface of the carcinoid tumor and inhibit the secretion of all those in compounds that it actually releases. Some treatments with radiation have also been discussed. In conclusion, restrictive cardiomyopathy is the least common among varying types of cardiomyopathies, and it can be idiopathic, familial, or secondary. Cardiac amyloidosis is the most common, and the EMF is the commonest cause in the tropics and subtropics. Prognosis is usually very poor because many of them don't present very early, and they present when the disease is already advanced. And then guideline-directed medical therapy, oral anticoagulants, antiarrhythmics, and cardiac pacing offer some supportive improvements in them, and advanced cases can actually benefit from heart failure. These are some of the references that were used for the slides. Thank you very much for listening.
Thank you very much. Thank you very much for the extensive presentation, three presentation in one. And we are grateful for the preparation and the time. At this point, we will kindly ask contributions and questions from colleagues, and after that, we go to our consultants and fellows on the call to help us point to us what exactly we should pay attention to, the most important areas. So kindly let's show appreciation to our presenter in the chat box, and also go ahead to unmute to ask your questions. Thank you. Hello, don't we have any questions, please? Dr. Corey, Dr. Moji.
Yeah, good evening, everybody. Eugene, I have a contribution. Thank you very much, Dr. Mokrede. Very, 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 very wonderful presentation. Excellently delivered. I want to contribute on the first part, that's the arrhythmogenic cardiomyopathy, especially on the, like you said, it's mainly autosomal dominant. Okay, but when you talk of Naxos syndrome is autosomal recessive, like you said. But what I want to say is, when you mention, Naxos syndrome is characterized by some dermatological lesions like woolly hair and palmoplantar hyperkeratosis. Now, when you talk of Carvajal syndrome is actually, it affects the right. So it actually has the same dermatological characteristics as Naxos. That's, you have the same woolly hair and you have palmoplantar keratosis or palmoplantar hyperkeratosis. But unlike Naxos, it causes a dilated cardiomyopathy picture. Okay, so it's important that we take note of that, because I think we've seen it in some MCQs. Okay, but it causes a DCM picture, not an ARVC picture. Then it's also important for us to know that although the name has many names, arrhythmogenic right ventricular dysplasia, but now the name is actually arrhythmogenic cardiomyopathy, because it has been seen that although the fibrofatty deposition is mainly in the right ventricle, but it can also happen in the left ventricle. In fact, there is also a type called the LV, I can't remember it clearly, but it's the type called the LV variant of arrhythmogenic cardiomyopathy that can exclusively affect the left ventricle, although it's not so, it's rare, because most times we see it affecting the right ventricle. So those are my contributions. Thank you very much for a good presentation.
Thank you. Thank you. Thank you.
Thank you very much.
Hello.
Right, so, yeah, hello.
Thank you, Dr. Demo, for the beautiful presentations. I just want to confirm something. Carvajal syndrome, does it affect the right or the left? Because the last comment, you were saying that it affects the right. I thought it affects the left also. So just one clarification.
Yeah, that's actually what I was trying to say. That affects the left. Carvajal affects the left, but it has the
Okay.
same cutaneous features.
Okay.
Why Naxo? So Carvajal gives a DCM, not an arrhythmogenic cardiomyopathy. That's what I was
Okay.
trying to say.
Okay. 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 Thank you.
Thank you very much. So we go to our consultants on the call, our teachers, if there's any contribution, guidance with respect to the topics presented.
Eugene, sorry, I also have a question before we go to the please.
Okay.
I actually forgot to ask that. Then let me also, when we're talking about restrictive cardiomyopathy, especially the iron overload cardiomyopathies, I want to ask, I don't know, I don't think you mentioned hemochromatosis. That's like the primary hemochromatosis, because what you mentioned were mainly the maybe sickle cell, repeated blood transfusions, and all that. So I don't know whether that is also part of it. Okay, whether it will give us the same restrictive picture. Okay, then also whether this drug, because you mentioned that the treatment for those ones are mainly what do you call it, blood phlebotomy, as in removing like 400 to 500 mils of blood. Whether there's this drug there is in hemochromatosis, there's ferroxamine, whether it's also be, if okay, you mentioned it. All right, thank you. So yes, thank you so much. Yeah.
Good evening, everyone. Hello, good evening.
Good evening, sir.
Yeah, I want to thank you for a very lucid presentation. In fact, with this presentation, it's a very high yield West Africa. You can have less than 50 questions from what you have presented today. Starting from the first thing you started with, constrictive pericarditis, the RCM, and the ARVC. Of course, in our question, I can remember they talked about the sex prevalence, is it equal, is males more in the MCQ state. I'm sure you will have treated it, or maybe you'll still come across it. And then it rarely affects the left. We know it can left can be affected, even though it formerly called ARVC. So those are the things you need to pay attention to under that. And then the CP, constrictive pericarditis and RCM, talking about the annulus reversal. Those are the things, a lot of things came out in that. The echo features and the also right heart catheterization, the differences between the RCM and the CP. And then going to the amyloidosis, the AN and the ATTL. I remember which one the gold standard scintigraphy about the ATTL. It came out in the MCQ, so you need to pay attention. Amyloidosis, whether it can come out either orals or even but MCQ in particular, the various types, and then the presentation too. And also the carcinoid. I remember carcinoid also came out too. So this presentation, if you can make it available to them, I think that would be very essential so that people can, because this is a very, very high yield presentation. Can't have less than 50 questions from me. It can't be less. And then those CMR endomyocardial biopsies, the amyloidosis, the stains that you use, and then the findings too, as opposed to the sarcoid, the non-casseting that you said. Those are very, and then when you talk of CMR with LGR, you talk about the basal affectation and then the patchy.
Mm-hmm.
So you need to pay attention to all that too. very essential. I think this is a very wonderful presentation. I think you should make the slide available. But this is a very high yield presentation. You did a great job. Thank you.
Thank you, sir.
Yeah.
Thank you very much. Thank you very much. Do we have any other contribution from our consultants?
Yes, good evening, everybody.
Good
I don't know
evening.
if I'm audible.
Please, you are.
Yes, thank you. In addition to what Dr. Ayodele said, I just want to allude to the fact that this is a very important presentation and the presenter has done very well. Just to pass one or two comments to what has been said already. So, starting from the points I think Dr. Charles Okuri made, it's important to note that hemochromatosis, apart from being secondary, can be primary, to be genetic, and it's actually associated with HIV gene, which is located at chromosome 6. And also important that hemochromatosis that present with either restrictive or dilated cardiomyopathy pattern. So both of them are fairly possible. We've already talked about the difference between concealed pericarditis and RCM, so it's a very important one. It usually comes and either MCQ or orals. For cardiac amyloidosis, it's important to note that because it may not come out straight, like it can be like a clinical scenario, but it's important that when you are having a scenario that talks about extracardiac involvement, nervous system involvement, and they paint a scenario of a discrepancy between voltage and muscle. That is, the patient having a severe concentric hypertrophy, which you expect to see high voltage on ECG, and you are seeing a very low voltage. Those kind of pictures. So cardiac amyloidosis is what will give you that kind of picture. So it may not come down straight, it might just be like a clinical scenario. So it's important to check out for those things that can point down to amyloidosis and be able to make the diagnosis. Other comment I want to make is because there was a year that ARVC came out as an essay question in which they asked for diagnostic criteria, which the president has also mentioned. But just to give a code that you can use to remember the revised task force criteria for the diagnosis of ARVC. I don't know if I'm still audible. Am I still audible?
Yes, you are. Yes, you are, sir. Yes, you are. Very audible.
We know that ARVC can cause sudden cardiac death, and when there's sudden cardiac death, there will be grief. This grief will not be, it will be normal grief that you know, it will be GREEAF. GREEAF, grief. So the first GR is global or regional akinesia, dyskinesia, or aneurysm that you notice either on echo or on CMR. You understand that? So that's the GR. Then the E is endomyocardial biopsy, which you want to look at for residual myocytes. And as the president has said, better than 60% the major criteria. This is more than 60 to 89% the minor criteria. So endomyocardial biopsy, the first E. Then the second E is ECG abnormality, which can be repolarization or depolarization. So ECG abnormality is second E for the code. Then the A is arrhythmia, which can be the non-sustained BT or sustained BT. And the F is family history. So that we can use as a quick code to remember the component of the revised task force criteria for diagnosis of ARVC. Thank you.
Thank you very much, sir.
Thank you very much. Thank you very much. We are grateful. Once again, thank you to our presenter. We'll move to the next session which is the MCQs. Thank you very much. So Dr. Charles Okori will share. I will join soon. Thank you.